I have a very good excuse for being late, and I'll tell you what it all is later. We have Dr. Edney today. Dr. Edney is going to talk to us about some of the things that are going on in the area of de facto access to healthcare, particularly as it involves the State Department of Health. Dr. Edney, this is not your first rodeo. You can proceed however you would like.
Thank you, Mr. Chair. Just have a seat right there. We always appreciate the invitation to share and visit with our two main committees of jurisdiction. And we're very happy to share with you our experience and expertise in terms of access to care issues in the state and to just let you know the data as we see it and as we have been drilling down into the issues that relate to access. It is important to understand that we have one beast in front of us at the health department and all of us in healthcare in Mississippi, and that is the beast of poor outcomes that I shared with you at some length with our first public health hearing. And you know, the power that the beast has is really multifaceted, and access to care is a big part of that. And access to care in and of itself is a complicated issue. It is integrated in many different areas that I will point out to you, and that integration piece makes it more difficult to unwind and to solve. And you know, it is very disparate, and that fact in and of itself leads to many of the disparities that we deal with in health in Mississippi. And so today I will present to you at a population level from the health department, but also remind you wearing my white coat. And when you see me in my white coat, that means I'm getting serious. But I need to remind you that I'm first and foremost a Mississippi physician, Mississippi license 12271 that I've held since 1988, very proudly. And that I'm an agency head a distant second behind that. So I serve as an agency head for one of your very important state agencies, always through the lens of a Mississippi physician. Having served West Mississippi as hard as I have been able to for over 30 years, and with a lot of experience in private practice and small town, 25 years of experience running the free clinic out of my church at First Baptist Medical Dental Ministry in Vicksburg, and now with the health department experience. But I also have with me today Dr. Dotson, who is a surgeon from Greenville, who will share with you the experience of being a physician in Washington County. And then Dr. Lampton, who is chair of the Board of Health, but who is also a family physician in Magnolia, Mississippi. And for those of you who don't know where Magnolia is, it is that last stop in Mississippi before heading into Louisiana on your way to watch the Saints play. It is a small town in Southwest Mississippi, and I specifically chose those two areas because they are significant areas of impact. So it's important to understand the drivers of health outcomes in Mississippi. You're probably not aware, but you need to be, that the most important indicator of your health outcome as a Mississippian has nothing to do with your income, or has less to do with your income, has less to do with your demographics. It has everything to do with your zip code. And you will see who recognizes 39110. Okay, that's Madison County. 39180, Senator Hobson's not here, but that is Warren County. So that is my home in West Mississippi. Madison County would have really nice health outcomes in general. Warren County kind of medium, and then 39113 is Issaquena County. And Issaquena County is the smallest population county in the state. It has no physicians, it has no clinics. It does have a dialysis unit, which I wish we didn't have to have one, but it has the only healthcare facility in Issaquena is a dialysis unit, which I think is ironic. And it's because of the health disparity of untreated hypertension and diabetes necessitating a dialysis unit in that low population county. And behind geography is education, and I would say specifically health literacy and understanding about the importance of preventive health, wellness exams, early engagement, prenatal care, and things, proper screenings. And access to health insurance is very high on the list, but it does not override the other factors. And very powerfully are the social determinants of health, which I have outlined in the will there, and they all interrelate with each other. Depending on different areas of Mississippi, you will have different levels in terms of access, social, political issues, food, housing, and environmental safety issues, economic stability, quality education. It just depends on your zip code and how powerfully those issues will impact you and your family. As you've heard me say before, it doesn't matter what kind of insurance you have if you live in Myersville, Mississippi, which is the county seat of Issaquena. So because you're going to be a long way from healthcare. So these issues are all very important, and they're all interrelated. So if you look at the map of Mississippi, you can draw a line right down the center, north to south, pretty much follow I-55. And as you go east of there, access is appropriate, more available, and easier. And as you get closer to my home in West Mississippi, it gets more challenging. And that is north to south. So as you follow the river counties all the way down, you will hit county after county after county, now including Warren County, although Warren County is kind of medium. It used to be high access, it's kind of medium access now. All the way down to Adams County, you will see access to care challenges, and you will see low investment in healthcare in terms of economic investment. You will see very few CON requests of any type west of I-55. And so we have an entire half of the state that struggles with access to care issue related to that geography that also incorporates all those other social determinants. I wanted to put before you what we're doing at the health department. So if you notice the region that's in red in the northwest sector, that is our brand new Region 4, which is made up of core Delta counties. And geography plays again, because in all the core Delta counties, the health outcomes are 15% worse across the board than the rest of the state. And the rest of the state still has significant outcome challenges. So what I have done is to take some of our workforce development opportunity from the federal level and invested in a region looking specifically at the challenges of the Mississippi Delta. And Dr. Dotson has agreed to serve as that regional health officer. She has practiced in Washington County for over 20 years. She and her husband, who's an orthopedist, live in Washington County, and she understands the Delta quite well, and she is going to help us as we try to make things better for the people that we serve in that region. Now, as we talk about, I listed for you the challenges with access. Then solutions that we've all been applying for quite some time that have been helpful include many of our partners. So we do have a network of safety net providers who are led by our FQHC partners, our community health center partners. We have the MQHC grant that goes out every year to our FQHCs so that they can use the sliding scale to help pay for the uninsured care that they cover. They are responsible, for just on the sliding scale over 76,000 patient visits a year through that really important grant. And they really lead the way for the safety net. They have robust federal funding. They do need the state funding that they get, and they're an integral partner with the Department of Health. And we're very proud to work with them. And I have visited several of them in the last 18 months and I'm amazed with their work. Then we also have our free clinics. And being the volunteer medical director for ours in Vicksburg, it's going to take a bit for me to identify all the free clinics around the state and all the good work that's going on providing free medical and dental care all over the state. Many of our faith-based partners are in that space. And it's probably somewhere around 25 to 30, but we don't have any specific organized tracking of the free clinics. And we're just grateful that they are plugging some of the hole there for the uninsured. And then you have your county health departments that we have 86 of those, and there are 86 of those in 80 counties. Issaquah and Sharkey share one. Benton County does not have one because of low population up in North Mississippi. But out of the 86 that are there, I've already shared with you, many of those are open a limited amount of time, and probably half of the rest are on a limited schedule, being open part-time, related mostly to staffing shortages and funding challenges. And then the other half are doing the heavy lifting. But at the health department clinics, we saw 266,000 clinical visits last year, 10,000 prescriptions per month. 65,000 WIC participants are being cared for, 1,400 healthy moms, healthy babies that are perinatal high risk, maternity patients, the moms and the babies, and approximately 4,300 cancer screenings that the health department does for free. And that really is still a drop in the bucket with the need that is out there. So best numbers that I can come up with, looking at the national foundations, such as the Kaiser Foundation, Trust for America, Commonwealth, folks that study these issues intensely, that we are probably running about 150,000 Mississippians that are uninsured, and those are those who are not eligible. So we don't count, if you're eligible for Medicaid but you haven't enrolled, then we just need to work to get you enrolled. And there are more out there than you realize. And then if you include the inadequately insured, that would be many marketplace, Affordable Care Act, exchange policies will have their relatively low premium, but they have an $8,000 deductible, and that is not health insurance. Now, I want you to, if you look at this graph, this is the percentage of the uninsured in Mississippi, and you will see that it has gone down, and that is largely due to improved uptake of marketplace. But and we need to lean into that. But many people don't understand that the marketplace policies have an open enrollment period. So you've got that limited amount of time to get folks enrolled at the end of the year. It closed January 16th. And at the health department, we try hard to enroll our eligible folks into Medicaid, Medicaid waiver, or marketplace for those who qualify. And we have closed our gap from 70% that had no payer source with our visits down to 42%. And that came through a lot of just the business principles I have been talking to y'all about, just running the health departments more as a business as they should be, and doing better at billing and collections, but also really being as aggressive as we can, getting our eligible patients enrolled in appropriate healthcare insurance. Because if you've not worked in that space, and if you've not had the pleasure of helping someone who's eligible to enroll into Medicaid or to enroll into Marketplace, it's very satisfying because it changes their life to go from having to go to a free clinic to being able to go and have a medical home and to have robust preventive care and screenings and the best medicines available. So if the graph is showing that we're still running just under 11% uninsured, which is an extremely high rate. And we're really looking at age 18 to 64. And that's the gap that I know that y'all are concerned about, and you're looking for solutions. And that's where the attention needs to be. And so lots of options available. A lot of study has gone into that. And, there are many ways to close that gap. But as we close that gap, all working together, then access to care improves and health outcomes will follow along with that. And I like to use the analogy that the Department of Health is like an aircraft carrier. We're big, we're fairly powerful in the space that we work, but we're unwieldy and it takes forever to change course, being a large bureaucracy. And we are utterly dependent on our partners, which is a good thing. And our partners are the FQHCs and the free clinics and our community partners, both in healthcare and out, faith-based and secular. It doesn't matter. I look at it as a convoy where the aircraft carrier is in the center, but you got to have battleships to protect the aircraft carrier. Those are the FQHCs. You've got to have everybody else who are the cruisers and destroyers who are more nimble and can adjust more quickly. But as we all work together, that battle group becomes very powerful. And we are able to put more firepower into that beast of poor health outcomes. And as we do that together, we will see fewer babies dying before they reach a year of age. We'll see fewer pregnant women dying. We will see fewer folks my age dying unnecessarily from stroke and heart attack. We'll have better outcomes across the board. And I am just of the mind that it is time to stop accepting where we are. It's not our fate to be at the bottom. I shared with y'all already how we've started to come up in some areas, and I'm convinced we can come up across the board and not just get off the bottom, but get off the radar. And so I want to, if it's all right with you, Ms. Chairman, invite my colleagues to come and share, and then we'll be happy to entertain questions if that's suitable to observe.
Sure, just proceed however
Thank you.
you think best.
Dr. Johnson.
Good afternoon. Thank you all for the opportunity to share some of my thoughts with you about practicing in an underserved area. I'm sure you've heard at some point or another Dr. Edney's recollections of why this work is so important to him as far as access to care is concerned, with the story about his father not having access and passing away from colon cancer. Well, for me, that reason for being amounts to a question of what's in a name. Whenever I see my name in print, or I say my name, or I write my name, I am reminded of why access to care is so very important, because in December of 1965, my then 41-year-old mother had a bouncing 10-pound, 8-ounce baby girl, me. And I was delivered at home by a midwife. All right, so by all purposes now, her pregnancy would be considered a very high-risk pregnancy because of her age. And the fact that I weighed 10 pounds, 8 ounces meant that she probably had gestational diabetes. And she had very little to no prenatal care. I was delivered by a midwife, but the thing that, to answer the question, what is in a name? My mother decided to name me Renee. And if you look at the paper, it's spelled R-E-N-I-A, but I have been known as Renee all of my life. And that is because the midwife, who was very good at her craft, but was probably functionally illiterate. And therefore, they didn't know how to spell my name. And so now I have a moniker that I'm quite proud of, but it also serves as a reminder of why access to care is so very, very important. And it is a reminder every day for me to do all that I can to make sure that the patients I serve do have the access and the care that they need. In doing so in a private practice in Greenville, it requires a good amount of imagination, ingenuity, and just doggedness at times. For instance, I've had a patient who was underinsured or practically uninsured. She sustained a very bad burn to her hand. I saw her in the emergency room, took care of her because I also, although I'm a colon and rectal surgeon, I also practice general surgery, and we did wound care for her, but she worked at the local Walmart. And getting her back and forth to my clinic was a challenge because she was not able to take the needed number of visits off from work. I didn't have morning office hours, but I knew that this was her hand. It was her dominant hand. And a good outcome was tantamount for her to be able to continue to work with her job and to take care of herself and her children. So we had to get creative about her dressing changes and her therapy. She couldn't afford the therapy appointments after a couple of visits, and she also didn't have the time off to make it to the therapy appointments. So she worked as a cashier at Walmart. The way we got creative and the way I had to take care of her is that I shopped at Walmart at the time that she worked at once a week. And so she and her friends had a pact. When I came in, I picked up all of my items that I needed in Walmart. When it was time for me to check out, miraculously, a lane opened for me with no other people in it. I went to her lane. She checked me out. I was able to, she would take her dressing down so I could see how she was healing. And I could also see her range of motion by the way she worked the scanner when she was scanning my options. So we had an office visit in the middle of Walmart that no one else knew was happening except for the two of us. But you have to get creative sometimes to do that. And that worked for her. There are other times when it gets very, very frustrating because it's like you're spitting in the ocean or trying to drink from a fire hydrant. And, you know, as a surgeon, we're used to cutting things out, putting it back together, have you work again, and you go along your way. Primary care and sustained care and chronic conditions are not in our wheelhouse. And certainly we don't want to be treating anything chronically because as surgeons, we're fix-it kind of people. And so I had another patient who had a prolonged illness with a bad case of a skin infection and needed visit after visit after visit. And sometimes you have to be willing to ruffle feathers at that too, because It would be wonderful if we practiced in a vacuum and everything worked according to plan, but this gentleman kept coming back and he needed repeated visits. He did not have insurance. And so then you're working within a system that says, hey, why are you not asking this guy for payment when he comes? I'm like, I can ask him, but he's not gonna give it to me. So because he doesn't have it, I mean, I can frisk him and turn his pockets inside out, but we're still not gonna create any money. But he's still gonna have this problem. And you can answer yourself as the physician as, I should not have to be dealing with this. I am a surgeon, but my husband and I have this saying is that you can either win the argument or achieve your objective. So in this case, I decided to lose the argument with the powers that be and everybody that was above me, but we're gonna see this guy. And I saw him repeatedly because in giving him consistent follow-up care, it decreased his number of ER visits, it decreased his numbers of hospitalizations, and it increased his overall level of care. And so it just takes a certain amount of committedness to doing it. It is not easy work. I would love to have a world where everyone had everything that they needed, but they don't. And we just have to oftentimes it takes a lot of creativity. It also leads to you getting tired, maybe a little bit of burnout, but we don't grow weary because there's nothing greater than having that person come back in with a healed wound, better living situations, better able to get around to do things for themselves. And the big smile and the big thank you is sometimes is all that you get, but sometimes you don't even get that, but just seeing them walking around is enough. And it's what keeps us going. And then of course, I have to write my name and I'm reminded all over again why I do it. So thank you.
Hello, everyone. I'm Dr. Luke Lampton. I'm chairman of the Board of Health, but my primary work is as a small town family physician in Southwest Mississippi. Magnolia is 10 miles south of Macomb, and we're one of the last exits before you go into Louisiana. There was a Greenville writer, Lewis Kahn, that wrote that the Mississippi Delta begins in the lobby of the Peabody Hotel and ends in Catfish Row and Vicksburg. And I love how he expressed that, but I always felt like he stops it too soon. I don't think it stops in Catfish Row. I think it keeps going south along the Mississippi River, and it goes through Fayette and it comes down to Woodville, may take in Natchez, and then it kind of takes a sharp easterly turn, and it ends on Railroad Avenue in Magnolia, Mississippi. And Southwest Mississippi is often, I consider it like the South Delta. It's a forgotten part of Mississippi that shares a lot of the demographics with the Delta. It struggles with poverty, and certainly it struggles with access to care. And probably when you think of access to care, there's a lot of dynamics involved, but poverty is a big one. In rural Mississippi, whatever you think about it, and most of y'all are from rural Mississippi, there's a lot of poverty there. A lot of people live in mobile homes, not fancy mobile homes, but mobile homes that have holes in the floor of them. I've done house calls and had to be careful not to fall in holes in mobile homes. People walk to my clinic, and not necessarily because they're trying to get exercise. Even our bank drive-through, I often laugh because I'll be in the bank drive-through and somebody will be walking through the drive-through. But beside poverty, I think access to care in our rural areas really centers around the healthcare workforce, which is struggling significantly in our rural areas. The work of John Mitchell at the Office of Physician Workforce has strategically improved the creation of family physicians and primary care physicians in our state, and that's going to have an impact in rural areas. When I first came to Magnolia, there were 4 physicians in my clinic, and right now there's 1 doctor in Magnolia, and that's me. And I have a medical home for my patients, and I purposefully call it a medical home. And I think that's what, you think about what rural residents want. They want y'all to help support a physician-led medical home. And it doesn't have to be all physicians either. I've got 2 nurse practitioners in my clinic, and they see more patients in my clinic than I do. But I'm there and I'm working with them. I'm handling the hospital load and the nursing home load. And we work as a team, a medical team, taking care of these patients. But if any of the patients need something, they have a home. They can come and speak to our nurses and get in with us and be seen if they have a problem. It's very difficult to operate a private practice primary care clinic in our rural areas. And if you look, they are becoming non-existent. Now, some private practice clinics and more specialty areas are thriving and doing well, but the reimbursements at primary care clinics in rural areas has dropped significantly. And also the requirements of operating a rural primary care clinic, if you are a medical home, you have to have somebody that can handle prior authorizations. You have to have somebody that can be on the phone talking with patients. We have 12 people beside the physicians, the physician and 2 nurse practitioners that just help take care of the patients and the nurses. And that expense has not really been met by what physicians get paid for primary care. And in the old days, we used to like insurance companies because they would pay better than Medicare and Medicaid. Right now, a lot of the rural doctors prefer Medicaid and Medicare because they can at least count on being paid for a service if it's provided. But that said, the federal government has recognized some of that, and they are allowing the creation in most rural areas of hospital-based rural clinics where they're basically cost reimbursed. And really, if we look at rural care and rural hospitals, that is the solution, is a cost reimbursed system, figure out a way to appropriately handle that. They've done pilots with that in Pennsylvania and have proven that it's a successful way to keep rural hospitals and rural clinics open that are critical to the infrastructure. One of the things that people focus on is the importance of an emergency room in rural areas. I'm not sure an emergency room is absolutely critical in every rural area, but I think a rural hospital is. I don't think if somebody's mother or grandmother that lives in a rural area and the citizens are poor and they have transportation issues, they don't need to have to put their grandmother in the hospital with a pneumonia 40 miles away. And the people in rural Mississippi want to be able to treat at least minor acute illness in their local hospital. And so if we focus on that, in Mississippi, one of the most brilliant things that this legislature and the department has done is the creation of systems of care. And the systems of care in Mississippi are so important for access to care in Mississippi. And Mississippi is the only state in the United States that has 4 systems of care. We're working on a 5th one. But we have a trauma system of care, absolutely critical for rural citizens. Why is that critical? Because you may have heard of the golden hour with trauma, but if you're in a rural area, 40 years ago, you would end up stuck in an emergency room with a significant trauma, and you could not be transferred anywhere for a long time, and it would take hours to get somebody with a gunshot wound out of a rural area. Now, the ambulances, if a gunshot wound will occur in a rural area, they go to the appropriate facility with that. And so you're able to accomplish what is referred to in the military as the golden hour, but you're able to get somebody with severe trauma to the right place at the right time. So if I can encourage you anything about access to healthcare in a rural area, support that system of care. The other systems of care are just as important, and the golden hour applies just as much with our stroke system of care. Somebody's having a stroke in a rural area, the ambulance can get them to an appropriate facility. There's coordination of care. You've probably heard of the STEMI system we have, which is an acute MI, which is also critical. Time means heart muscle. And we have a system that takes people where they need to go And we're contemplating, or in fact, we've begun work on an OB system of care for high-risk OB citizens, which will also prove critical to our rural citizens. So those things, what they do is they take a lot of the acute stuff, the emergency stuff out of a rural area. And if a rural area and the rural hospitals are there, don't have to deal with always transferring these other people to other facilities and trying to do that, they can focus on preventive care. And but the hospitals are still necessary. And I think actually acute beds in our rural areas to treat the local citizens for low acuity stuff that still requires hospitalization so they can stay close to home is still something that most rural citizens would say, that's very important to me. I don't want to go 40 miles to be treated for cellulitis that could be treated with IV antibiotics in my local hospital. As far as the healthcare workforce in rural areas, a lot of it's how much you can pay people, and also it's the education system. But a lot of the rural citizens that are trained are captured with higher dollars in our urban areas. If you talk to any of the hospitals in rural areas, you talk to any of the clinics in rural areas, you talk to any of the nursing homes in rural areas, they struggle to get nurses. They struggle to get, of course, they struggle to get physicians. They struggle to get nurses, especially RNs to work in the hospital and LPNs to work in the clinics and hospital. They are difficult to find, and our nursing homes struggle to fill shifts. And there is a huge need when you look at access to care in a rural area for your continued focus on the needs of our healthcare workforce. And when we also look at physicians, as we develop some of the infrastructure for the primary care physicians that Dr. Mitchell has done, we need to start looking at fellowships, such as there was an OB fellowship for family physicians in Meridian that was recently announced. Things like that will give more access to care in rural areas if we can come up with some creative fellowships in OB to provide more obstetricians in rural areas. There are no OBs in Magnolia, and you've got to drive to Macomb, which most rural citizens are used to driving places, okay? They'll drive a long way to work and they'll drive a long way, but they also, when you start looking at that, our rural citizens have high rates of deaths driving places, okay? You look at motor vehicle accidents and you look at friends of mine and their children. I've had friends, probably more friends die in car wrecks in rural areas than in other places. It's a high mortality risk when you live in a small town because you're on the road so much. There are also a lot of insecurities in rural areas, not only healthcare insecurities, but there are not a lot of places. You've heard of food deserts. I heard a term the other day, and a food desert is where you can't find healthy food to eat. And it is very difficult. I remember when I came down to Magnolia, unsweet tea was non-existent. You went somewhere, you didn't have to ask whether it was sweet or unsweet. It was always sweet. I think rural Mississippi, and especially because of some of the education in schools, people are expecting more. You can go in the dollar store, and they usually have some fresh salad, and they have some fresh vegetables. There seems to be a more concerted effort to provide good food to our citizens in rural areas. I think, though, there is a significant amount of education that we need to engage in to encourage them to do that. But I think physicians and nurse practitioners and our nurses are working on that and trying to get people aware of the Mediterranean diet in ways they can shape the Southern and soul food diet into the Mediterranean diet, which actually it's a lot of the same food. And here, if you look at the American Medical Association has often criticized that the Southern diet is one of the reasons that we have such high risk of hypertension and diabetes and various health-related cardiovascular disease. However, if you look at the Mediterranean style diet, it involves vegetables. It involves, perhaps we'd have to use olive oil instead of bacon drippings, but the rest of the ingredients are what we grow in the South. And if you think of the Mediterranean area, it's a Gulf region, kind of like we are. So the South and Mississippi ought to be able to transition to this healthy diet without too much discomfort. It'll just be education. And with that, I probably bored y'all enough. But I do think the work that y'all do, though, makes a huge difference in rural areas. And y'all's attention to the needs of rural citizens and asking what do they need, and helping keep our rural hospitals open and to help keep them having not just an emergency room, but acute beds where they can take care of patients. And is very important. And also thinking about a way to support the medical home, the small town clinic that's trying to care for the patients there. Everything y'all are doing to try to keep physicians going into rural areas and nurse practitioners working with them as a team and nurses going to rural areas and taking care of patients is all very important. And I appreciate your work.
Thank y'all. So you heard the stories of two of my colleagues, and I see a few more. And what you heard is real life examples of what I shared with you in the first hearing, and that was to focus on the needs of the patient, and everything else will take care of itself. And you are looking at physicians that do that every day. I would remind you, there is no DISH program for clinics. There's no disproportionate share for doctors and nurse practitioners and PAs. There was no DISH money that went to Dr. Dotson for going to Walmart to take care of that worker who couldn't get off work. There's no disproportionate share for those of us running free clinics. This is a complicated program, multifaceted, integrated, and disparate. But for every problem, there is a solution. And if all the problems were easy to solve, we wouldn't need to be here. So what I would encourage you to do as you work through this session and others, that you focus on the needs of your constituents who are patients of someone. And if you focus on the needs of your constituents, everything else will take care of itself. That's not a Dan Edney principle. That's actually a medical principle that we learned early in our training. And I can tell you, as a gray-haired doctor, it is very true. And I want to share this. You know, I got to tell a story. And my staff are rolling their eyes, but I got to do it. The last Rural Health Summit, I had 2 rural health scholars, and bravo for your wisdom in those programs. One is a family medicine resident finishing and going to Lexington, Mississippi, and she will be the only doctor in Lexington. The other is a brand new pre-med graduate going to med school on the scholarship. The first physician said, Dr. Edney, I'm really worried going to Lexington. I don't know if I'll have enough patients who will have insurance to cover my overhead, which is very high after the pandemic. Payments are flat across the board. Actually, doctor payments are lower than pre-pandemic, and costs are up 20%. And if you're a business person, you know what that means. And she was legitimately worried that she would not be able to make it. She said, what do I do? And I said, well, join us as we are looking for solutions, be politically engaged, have relationships with your legislators, and advocate for your patients, and always take care of the needs of your patient, and everything else will take care of itself. The young man who is just entering medical school asked me the same question, believe it or not, exact same question, same day, same question. I told him, buddy, don't worry about it. We're going to have this figured out long before you graduate. And I believe that. And I believe us all working together, looking at the options on the table, the only option that cannot be on the table is doing nothing. Because there are too many options that will work to improve the access to care for Mississippians. And as I've told you, as the youngest child of a low-income family in the Mississippi Delta, who my mother and father would have never taken welfare for anything. They believed in working and paying their bills, but you can't pay medical bills these days without filing bankruptcy. So let's look after the needs of our folks, and everything else will take care of itself. Mr. Chairman, we're happy to answer any questions if there's time.
Could you go back to the slide that had the figures for the state health plan?
Oh, I'm sorry, yes. The reason I put the numbers for the state health plan, the Blue Cross plan for state employees, which covers me, is to show you what inadequate insurance can look like for low-income state employees. Right there.
There we go.
So
I'd like to think about a family that at one point was a traditional family with a father that worked and a mother that stayed home and took care of the children. So let's think about somebody trying to do that. A family of four, husband, wife, boy, girl, cat, dog. And this guy's working for the state and earning $30,000 a year. As best I can see that, if this individual gets coverage for his spouse and children, it's 8 times 12, which I think is about $10,000 a year for health insurance
with a deductible.
for that family. If you're earning $30,000 a year and working for the state, your Social Security and your retirement system is about 15%. So that's roughly another $5,000. So that's $15,000 left over after those two items. This individual goes to the grocery store, buys groceries for the family. There's a 7% sales tax on that. And we haven't even gotten to the $3,600 a year deductible and something for a house and a car and car insurance and house insurance and maybe clothing for the family. I should mention in this instance, of course, the spouse who's staying at home and taking care of the young children will, of course, get beat up on for not participating in the workforce. And anytime you see these charts about the workforce participation rate, think about exactly who it is that's not in the workforce. And it's this individual sitting at home, taking care of children, not to worry about the 10th graders in retired military. But at any rate, if you are in that situation and you've got a $3,600 deductible, you're not going to be able to access your health care much at all. I mean, that's just $10,000 a year. And unless you can run up $3,600 worth of health care, you're in the same situation as being uninsured. We can't solve all of those problems. But the state of Mississippi designed that healthcare plan. The state of Mississippi designed those deductibles. The state of Mississippi chose to have those dollar amounts for the premiums because we could have subsidized the plan and not had those. So when you hear all this crying and patting ourselves on the back about all this money we've got in the bank and how we're being frugal and holding down spending and all of that, we're holding down spending on the backs of the $30,000 a year person in this situation. And there are a lot of folks working for the state earning less than $30,000 a year. That's not what you were here for, but you're the one that put the chart on the board. So what do you expect?
No, I couldn't think of a better example that I have to deal with every day because I have too many employees that are state employees. My federal employees, my federal funded pens, I've got plenty of funds, but my state pens I struggle with. And that's why that's part of my appropriations ask is to take the employees you're talking about and help me get them up to where, you know, they're not choosing between healthcare. They don't have a choice about PERS. They have to contribute to the retirement, but they don't have to take the insurance. And too many state employees are opting out of the state plan. Many are going to the exchanges. And then many are going uncovered. And this is a common discussion among agency heads about an issue of the inadequately insured workforce of state employees.
But if you go to the exchange, you've got a fairly nice deductible there also.
Yes, sir, depending on your income level. And since the Inflation Reduction Act, the subsidies are much higher than they were before the pandemic, but there's still that gap there. Yes, sir.
Chairman Creekmore, did you have?
Yes, sir. Thank you. First of all, Dr. Edney, I've thanked you several times. Thank you for your service. But Dr. Dotson, Dr. Lampton, thank you for all y'all do, especially in the Mississippi Delta and what compelling stories you bring to these committees. On the Delta region, I think I counted 13 counties. Is that right on your graphic?
Yes, sir.
All right. And how many hospitals do we have in that region?
We, in the core Delta counties, we have 4 acute cares, but one of those is Greenville LaFleur that is fighting to downgrade to a critical access. Clarksdale is also planning to downgrade to critical access, and that will leave Bolivar County in Cleveland and the Delta Health Medical Center, the old Delta Regional in Greenville will be the 2 acute care hospitals in the core Delta counties that will remain.
And in your opinion, that's not adequate?
No, sir. The thing that worries me the most in strategic planning for healthcare infrastructure is where we are with the Delta. And Dr. Dotson and I have talked a lot about the fragility of healthcare in the Delta. The enhanced Medicaid funding was helpful. That's, it's not enough, but it bought them some time. I was contacted by a CEO from the South Delta that I know well, that they're moving to rural emergency status. And he said, I've got 60 days of payroll if I can't get some type of funding that we'll have to shut down.
And if we look at the regional approach to it and give certain hospitals certain specialties, still we're going to be driving more than that hour for that critical care?
Yes, sir. Right now, for certain levels of care, you have to leave the Delta entirely. There are no options. There's no NICU. There's very limited cardiovascular coverage. Orthopedic coverage is spotty. GI coverage is spotty. And what has really worried me is the number of hospitals that during the pandemic, their ICUs were running at 200% capacity, keeping their folks alive who now have no ICU at all. And I can name 2 hospitals in that situation right now that they were open, busy, full through the pandemic, and now they can't afford to keep an ICU at all. So it's an hour is actually pretty good for the Delta for a lot of things. And because we're looking at some areas that it's more like 2.5 hours to care.
So would we need to take that Delta region and split it into 2 sections?
Well, yes, sir. It's interesting. You're here to talk about the core Delta, and that's those 13 counties.
The 13 counties.
But Dr. Lampton is right. When you talk about like the Delta situation, you've got the bump at Warren County, then you go right back down into Claiborne and Jefferson, and then move towards, Franklin and Wilson, Adams. It all starts looking the same again. And it's the same challenges as Washington and Bolivar and Tallahatchie. It really just follows the river right on down.
And I know we're talking about healthcare as a whole, but I'm particularly interested in the Delta region. That's all I have for now. Thanks.
Yes, sir.
Questions from members of the committee? I see no questions. Anyone, anything else? Go right ahead. Am I supposed to say the gentle lady from Honda Talk? I'm going to learn this lingo.
Oh, there we go. So this is kind of more of a question for some of y'all that are more experienced. When these bills come through for the state health insurance, are they automatically assigned to insurance committee? Or could they be assigned to public health where they could be looked at from a different perspective other than just an insurance perspective?
Trust me on this. The presiding officers can refer any bill to any committee or committees. But what happens is a practical matter, and I think I'm right about this, I don't know, is that generally speaking, everything connected with this is more or less on internal power that we've designated to the committee and all to make decisions about it. And as so often is the case, it's just as it is with Medicaid, the one metric that trumps everything else in this building is cost. And there is more focus, and historically has been more focused on the cost of Medicaid to the state and the cost of the state health insurance plan to the state than whether anybody, whether we alleviate human suffering or people live or die. But that doesn't really come up. We just focus on the cost. Thank you for coming. You've given us all something to think about, and that's what we had.
Yes, sir. Thank you so much.
And thanks to the rest of you for coming. I will say that I think our plan for next week is that we will not meet on Tuesday, and that the final hearing that we have will be Wednesday of next week. It will be a fairly important hearing. Chairman Creekmore will be presiding at that hearing. And I think that will sort of bring to an end the hearings that we're having, simply because now that we have deadlines, we've observed that the deadlines loom, and we probably need to shift to dealing with legislation. Anything? Let me just make a couple of quick remarks to the Senate members since I have you here. It is my intention before 10 o'clock in the morning, of course, I don't always do things I intend to do, to name 3 subcommittees for the purpose of just looking at some specific pieces of legislation, and to assign pieces of legislation to those subcommittees. It would be my hope that the subcommittees would have some one or more public meetings to have people comment on that legislation that want to, and that also would look carefully at the actual words of the legislation to see if there are any technical issues with the words, and then tell me what you think about it after that takes place. Now, try to get that on your desk by 10 o'clock in the morning, but you know me. If there's nothing else, again, thank you all for coming. We stand adjourned.